Hi, good afternoon. Thank you very much for inviting me. I thank Professor Lucas, and it's my honor actually to be among the giants in skull-based surgery. It feels a little difficult to talk about gamma knife when I have very good surgeons that could take care of all these tumors we are going to talk about. But that will be talk about a tool which is for and by neurosurgeons. So when we talk about gamma knife, we have to talk about Lars Leksell, a Swedish pioneer in field of neurosurgery. And this picture is well known to most of us, where we can see Professor Lars Leksell with his frame, which is named after Leksell frame. Actually, Lars Leksell was behind his time and before his time, and he was talking about the future and his idea about gamma knife to focus radiation into one point to treat brain tumors and other lesions was really a pioneer. And usually when we talk about the Lars Leksell, we used to see the Q-tip full with the tool still a full as if it was Q-tip by him, but this is not real. But gamma knife is something for an expert a neurosurgeon to be used. This is Lars Leksell with the prototype in 1968 and his first patient where he treated the patient when he treated. And as we know, the gamma knife has 92 cobalt sources that treat an exact point with very good accuracy in the brain. So this tool is only for brain lesions, and with the new gamma knife models, you can treat also upper cervical tumors. These are the models which started in 1968 with prototype in the U and B and C models, then 4C, and 2016 we got the perfection, and now we have the icon with an arm which is a CT where we can use the frame or the mask to treat the patient. And as we know, gamma knife is behind all stereotactic, is more, there are more studies and more patients treated by gamma knife than by any other stereotactic radiation therapy. There are now more than 1 million patients treated and over 2,800 or 3,000 already peer-reviewed articles about gamma knife. And I would like also to present the MRI Focused Ultrasound, the exablate from Insightec. And the idea behind this is also Lars Leksell. As you know, his idea before the cobalt was ultrasound, and in 50s and 60s, the technology could not help him to bring to make the ultrasound to penetrate the brain in points. But now, by this machine, you can target very small lesions in the brain, and this is now FDA approved for tumor treatment by lesioning, and there are still a lot of studies ongoing for treatment of brain tumors. This has also other components which treats some gynecological tumors and also prostate cancer. Let me start with complication of skull-based surgery. And as I said, there are not always experienced skull-based surgeon available in all countries of the world, but these are the commonly reported complications of skull-based surgery, like meningitis, CSF leakage, visual changes, cerebral infarction, subdural hemorrhages, abscess, hydrocephalus, and you name it. And these complications could happen to any neurosurgeon. And let's have a look on the possible gamma knife risks and side effects, if any. The most common are the headache and maybe the brain edema, but many centers, they give the patient cortisone before the treatments. The loss of hair and nausea and vomiting, they are very, very rare. Numbness and weakness, they are also rare. Seizures are not common in skull-based treatment, but still they are very rare, and they are in only 0.004% of cases. Temporary or permanent hair loss, as we said, they're extremely rare. difficulty with balance is possible, and vision of hearing deficit depends on the tumor and location. And also, I would like to show that the focused nature of stereotactic radiosurgery as compared to other radiation therapies spares healthy surrounding tissues. And the gamma knife technology especially delivers 2 to 4 times less radiation than other radiosurgery systems. I went through at least 56 papers, and it was mainly about meningiomas, specifically petroclival schwannomas, glomus jugulare, pituitarynomas, chordomas, capinomas, and metastasis. And let me tell you that nowadays you can treat more than 14 metastases in the brain. I'm here talking about small metastases, and there are some papers talking about 20 metastases which have been treated by gamma knife. This is a study about gamma knife surgery in the treatment of intracanalicularis vestibular schwannomas, and I'm gonna just show very few cases, very few researchers that I think they are of importance. In this study, we had 136 patients with intracanalicularis vestibular schwannomas who had gamma knife between 2011 and 2015, and mean age was 54, mean duration of follow-up was 52 months. The tumor growth control was obtained in 91% of cases. Hearing improvement was observed in 32 patients, and there was a distinct cluster of 9 patients regaining serviceable hearing after gamma knife treatment, whereas 36 patients were stable. 4 patients developed facial nerve dysfunction, including 3 periodic hemifacial spasm. 1 patient had partial paresis was resolved spontaneously within a month. Within 12 months of gamma knife after gamma knife treatment. None of the patients showed new debilitating neurological deficits, including trigeminal and sensory disturbances or hydrocephalus. And in conclusion, gamma knife treatment is a highly effective treatment for intracanalicularis vestibular schwannomas associated with low morbidity and good tumor growth control. In this study from Sean Roger's team, hearing preservation after gamma knife radiosurgery for vestibular schwannomas presenting with high level hearing. They had 74 patients with minimum 3 years follow-up after gamma knife treatment, aged 17 to 76. 78.4% of the patients had functional hearing. Tumor control achieved in 93 of the cases. So preserving functional hearing was higher in patients who had an initial symptom other than hearing decrease, in patients younger than 50 years, and in those treated with a dose to the cochlea of less than 4 gray. So you protect the cochlea before treatment by having it less than 4 gray, less gray gamma knife to the area. In conclusion, probability of preserving functional hearing in the long term after gamma knife treatment for patients presenting with unilateral vestibular schwannomas is very high. The positive predictive factors appear to be young age, an initial symptom other than hearing decrease, and a low dose to cochlea. In this study, fractionated gamma knife radiosurgery is safe and effective treatment approach for large volume intracranial melanomas. There was a single session with gamma knife treatment for 42 patients. Median volume was 15.3 cubic centimeter. Median dose was 12 gray. Median follow-up was 57.8 months. Fractionated gamma knife treatment for 28 patients. A median tumor volume was 21 cubic centimeter. The median dose was 7.5 gray in 2 fractions, 6 gray in 3 fractions, and 4.5 gray in 4 fractions. The median follow-up was up to 50 months. So 33.3% complications in single session where the dose was high, and there was 5 hemiparesis, 4 seizures, 3 peritumoral edema, and 2 hydrocephalus. 7.5% complications in fractionated gamma knife treated patients with 2 hemiparesis. So with fractionated, the complications are much less. In conclusion, when the large volume intracranial meningiomas are expected to have high morbidity after microsurgery, and for patients that have a poor medical status for surgery, fractionated gamma knife can be considered an alternative with good tumor control and lower complications rates compared with single session gamma knife. And remember that gamma knife used to be for lesions 2.5 centimeter, all 3 centimeter and not more. And in large cases, surgeons used to remove the most part of the tumor and keep the rest, which are smaller than 2.5 centimeter, for gamma knife. But this study is good for fractionated. This is another study for the skull-based meningiomas. Fractionated gamma knife radiosurgery for skull-based meningioma is a single institution experience. They had 25 patients between 2013 and 2018. Mean volume was 7.6 cubic centimeter. Medium margin dose was 25 gray, delivered in 4 fractions in 8% of cases, or 5 fractions in 92% of cases. Median follow-up was 12.4 months. 2 patients experienced new onset cranial neuropathy at first follow-up. 6 patients experienced improvement of cranial neuropathy at first follow-up, and 3 patients developed symptomatic mild perilegional edema at first follow-up. In conclusion, fractionated gamma knife treatment with a relocatable, non-invasive immobilization system is well tolerated in patients with skull-based meningiomas and demonstrated satisfactory tumor control as well as limited radiation toxicity. This is another study about gamma knife radiosurgery for glomus jugular tumors, a single center series of 75 cases. And we know that glomus jugular cases usually they present in large volume and they are really difficult to remove without complications. The data was between 1994 and 2010, 75 patients. 47 had gamma knife, median age was 55 years, the median tumor volume was 7 cubic centimeter, and median follow-up was up to 38.5 months. They had tumor control in 93.4% of cases, improvement in pre-existing deficit noted in 15 patients, a stationary clinical course, and no progression of symptoms were noted in 48 patients, which are 64% of the cases. 12 patients had new symptom of progression of their pre-existing symptoms. So in conclusion, gamma knife radiosurgery offers a risk versus benefit treatment option with very low cranial nerve morbidity and stable long-term results. And let me show you some cases from Dr. Deepak Agrawal from All India Institute of Medical Sciences in New Delhi. This is a skull-based meningioma with 4 years follow-up. And as you see, that this volume is high and very good follow-up and a reduce of size and after 4 years of follow-up. This is a glomus jugularis follow-up in 4 years. And I see this a large tumor and there is reduction, and these are the images after 5 years. This is giant acoustic with 6 years follow-up, and glomus jugular in another patient after 3 years follow-up. So in conclusion, gamma knife is safe and can be suitable in selected skull-based lesions, small or giant. As skull-based tumors need expert surgeons, gamma knife needs experience for best outcome. Gamma knife still better outcome and decreased toxicity compared to other radiotherapies. Gamma knife is a tool by and for neurosurgeons and not against neurosurgeons. And again, a fool with a tool is still a fool. Thank you very much.